Welcome, everybody. We are going to give everyone just a couple minutes to get on here, but today we are going to be talking about the treatment strategies for peripheral arterial disease. I'll be your presenter today. My name is Gabrielle Artemovich. I am a cardiovascular nurse practitioner at the University of Michigan in Ann Arbor in the Division of Vascular Surgery, and we will have four presenters following us today. Those four presenters first are Ann Luciano, who is part of our multidisciplinary PAD program, Dr. Grossman, professor of internal medicine, Dr. Kaja, who is the professor of radiology and cardiac surgery, as well as the vascular and interventional radiology. And lastly, we have Dr. Corriere, who is in the vascular surgery department as well. So once we get through our welcome remarks today and a few housekeeping items, we'll have four presentations. First, the program overview and approach to patient care, followed by the quality of life for patients with peripheral arterial disease. Next, the medical management of patients with peripheral arterial disease, followed by structured team-based approach to the treatment of claudication. We'll allow for questions throughout the presentation and also have a time at the end before our closing remarks. These are learning objectives that we wish to accomplish today, as this is an accredited CME activity. We want you to be able to understand and utilize the guideline-based approach to diagnosis and medical management of peripheral arterial disease, including diagnostic testing, risk reduction, pharmacotherapy, and exercise therapy. Understand and apply the treatment options for patients with claudication symptoms, including exercise therapy, pharmacotherapy, and selective use of revascularization. Understand the advantages of multidisciplinary team-based approaches to peripheral arterial disease management. And lastly, understand approaches to lower extremity revascularization, including endovascular, surgical, and hybrid approaches. For this webinar, we ask that you all remain muted, and this session is being recorded currently. If you have any questions or concerns, you can go to the chat function and message the facilitator. This is where you'll be sending your questions as well. So again, make sure you enter your name in the chat box or scan this QR code. We'll leave it up just for a few seconds here so you guys can scan this. Again, you can go to the chat function on your screen at any time during the program, reach out to us with a question or if you need any assistance. These are the financial disclosures listed on the screen. Dr. Kaj has a few disclosures listed. And again, there's no other relevant financial relationships to disclose for this activity. Again, to get credit for your participation in this webinar today, you can use the QR code to register. Again, all the accounts you need to have a login for, and then you can claim the activity through the University of Michigan Medical School. And this will be again recorded so you can reference this after the webinar. But again, feel free to use the chat function if there's any questions about logging in, registering, or claiming the CME activity. Here at the University of Michigan, we have multiple locations that we can treat peripheral arterial disease in Ann Arbor at the Frankel Cardiovascular Center, at the Northville Health Center, and the Brighton Center for Specialty Care. This is how you get a hold of our services. So all referrals and consultations go through the M line. So it's an 800 number, 1-800-962-3555. So with that being said, we're going to go ahead and get started with our first presenter. First up, we'll have Ann Luciano. Again, she is a nurse practitioner in the Frankel Cardiovascular Center. She is the lead nurse practitioner for the multidisciplinary PAD program, and she will be talking first today. Oh, Ann, I just want to let you know, I think you're still muted. And then, again, her topic today will be the program overview and approach to patient care. And just give us a few minutes to get the presentation up, and then we'll go from there. Meantime, I'll check the chat. I know we have lots of different participants today across the whole country, which is very exciting for us here today.
Okay, now, can you hear me now?
Yes, thank you, Ann.
All right, awesome, thank you. So want to talk a little bit. We have a multidisciplinary PAD program. The Frankel Cardiovascular Center opened in 2007, and the Frankels were very interested in looking at collaboration between services and innovation of new product. And when the Cardiovascular Center leadership looked at the different programs, they felt that PAD was a program that that needed a little bit of help. At the time, we were not really practicing guideline-based medicine. Treatment options were very different depending on the specialty, and even within specialty at the provider level. Our outcomes were not very good at the time. This is Blue Cross Blue Shield PVI registry data looking at patients who had procedures in 2008. And you can see that our aspirin and statin use post-procedure did not meet the statewide goals. Our in-hospital transfusion rate was extremely high. And while we did meet the goal for vascular access complications, we weren't doing a very good job. So leadership brought together faculty who was treating PAD, and that included vascular medicine, interventional cardiology, vascular surgery, and interventional radiology to see what we could do to improve care for patients with PAD. CVC leadership gave us shared clinic space and resources. They actually paid for a full-time FTE for a nurse practitioner and a part-time RN to run the program. As a team, we got together and developed guideline-based management for patients and how we wanted to see these patients and run them through the clinic. We were also able to work on maximizing our procedure areas, and we used a patient-first scheduling option. So if the ORs were full and a patient needed an angiogram, then we could send the patient down to the cardiac cath lab and have the angiogram done there to kind of smooth out the timelines for patients getting their procedures. We had program designated time in the procedure areas, so we didn't have to fight other disciplines to use rooms. And then we had attendings who were willing to use other procedure locations to help patients get procedures. It's been about 13 years since we started the PAD program. Current practices, we have physicians scheduled for daily clinics. As the NP, I run the clinics and see all the patients. I staff new patients with physicians, but I see the return visits on my own based on our guidelines management. All of our patients get assessed for guideline-based care, and then that's managed. Each visit we see them. We're using Epic for further outreach. E-consults is a new option that allows physicians within our health system to contact us if they have any questions about care for PAD patients. We can do e-visits, which is having the patient do their outside follow-up studies, and then we can manage them through portal messages as opposed to seeing the patient. And these could be used for very stable patients that are years out from their procedure. And then we're also doing a lot of virtual follow-up. Our new program goals are partnering with podiatry and a smoking cessation team to give better care for the patients. And this is the Blue Cross Blue Shield and the SVS PAD registry data from 2021. And you can see that we've done a nice job of increasing our antiplatelet and statin use at discharge Our transfusion rate has come down pretty significantly, as has our post-procedure complications. Um, our patient experience percentage is 96.1%, and I believe that question is, did you have a good experience with your provider today? And it's a yes or no question. And then they also have a question on how do you rate your provider on a scale from 0 to 10, 0 being worst and 10 being best. And we have a 9.72%. So I think patients like the way we're managing things and like having an NP as a contact person. And again, if you need us for any reason, here's our contact information. We're happy to talk to you about a patient or see a patient for you. Thank you. Gabrielle, it's you.
Thank you, Anne, so much for that presentation. Next up, we will have Dr. Grossman. Dr. Grossman is a professor of internal medicine in the Division of Cardiovascular Medicine. His clinical interest is catheter-based treatment of coronary, peripheral arterial, structural heart, and valvular heart disease, along with quality improvement in the management of peripheral arterial disease. His presentation today is quality of life for patients with peripheral arterial disease. So I'm going to pass it over to you, Dr. Grossman.
Thanks, Gabrielle. Wonderful to be with you tonight. Thanks for joining us. We're really excited to have this opportunity to share our program with you and obviously assist in management of your patients with severe peripheral arterial disease. What I'd like to do over the next few minutes is talk a little bit about how we can assess quality of life in our patients, particularly those with significant peripheral arterial disease, the impact that this condition has on our patients' overall health status, and how using appropriate revascularization, patients can have an improvement in their reported quality of life. So patients with chronic systemic disease suffer from impaired health status and quality of life. Most of us are aware that patients with congestive heart failure or significant peripheral COPD have an impaired quality of life, and this can be tracked, and improvements in quality of life can be seen in patients who receive appropriate therapy for this. Certainly, patients with significant peripheral arterial disease also suffer from limitations in their quality of life. They can have physical pain, limitations in their mobility, emotional strain, and impaired social function. These are patient-reported, patient-measured outcomes, and now there's some wonderful tools that allow us to objectively measure this and even potentially track this as patients move through treatment for their peripheral arterial disease. Patients with PAD have significantly impaired quality of life. Those with claudication can have relatively mild symptoms to very severe impairment in physical function and overall quality of life scores. And patients with more severe disease that's manifest by critical limb ischemia have severe impairment in physical function, often have high pain and poor overall quality of life scores. As most of us know, individuals with severe lower extremity PAD avoid ambulating. This can lead to decline in their functional capacity. There's also high risk of social and emotional deficits in these patients, and these patients are less likely to participate in social activities and even to continue to work. There are several standard peripheral arterial disease questionnaires. One that we've used very successfully in the past is a measure called the Peripheral Arterial Questionnaire, or PAQ. This is a 20-item patient-reported health status measure. It can be self-administered. It's been validated. It's quite reliable, and it's very reproducible. It's extremely sensitive at detecting clinical improvement associated with lower extremity revascularization. And we're going to talk a little bit more about that in a second. Scores are developed for specific domains, and overall, the PAQ is on a 100-point scale, as most quality of life questionnaires are. The different domains include physical limitation, symptom frequency and duration, symptom stability, how the disease may be impacting social function, overall quality of life, how satisfied are the patients with the treatment of their disease, and a summary score, which combines these. Higher scores indicate less physical limitation, fewer symptoms, and greater treatment satisfaction or better quality of life. The PIQ, as I mentioned, is on a 100-point scale, so a patient who has a score between 80 and 100 really is not at all limited. And I think that's where most of us hopefully are on this call, and most of us would like to see our patients. Those with scores of 60 to 80 are only slightly limited. Patients with scores in the 40 to 60 range are moderately limited, and these patients can have significant limitations in their ability to perform activities. And those with scores of 20 to 40 are actually quite a bit limited, and certainly the disease has very significant impact on their daily activities. And finally, those with scores of 0 to 20 are extremely limited, may have difficulty performing activities of daily living, even ambulating around their home. So what are the goals of revascularization in peripheral arterial disease? And we're going to talk a little bit more about this in subsequent talks, but certainly lower extremity percutaneous arterial interventions can be first-line revascularization strategies for many patients with claudication or critical limb ischemia after appropriate medical therapy, and they're performed to improve the quality of life of patients with symptomatic PAD. We sought to find out, and many other studies have used quality of life questionnaires to see if we can objectively document improvement in these scores with revascularization. There have been several trials which have used these measures, including the CLEVER trial, the Stroll trial, and the Liberty 360 trial. These are all trials that included arms of revascularization for severe peripheral arterial disease, and all have demonstrated there was an improvement in quality of life scores with revascularization. I'm going to talk a little bit about our statewide experience in our PVI registry. The study population that we focused on was over 13,000 patients collected from 47 hospitals across the state who were doing revascularization procedures over the last 10 years. The indication for the procedure was recorded. The majority were for claudication, but almost 6,000 were for patients who had critical limb ischemia, as manifest by rest pain or non-healing ulcers. Data was collected as part of a statewide registry, as I measured using the peripheral arterial questionnaire. We collected data at baseline before the procedure and then 6 months after the revascularization procedure. And again, this is a 100-point score, 100-point scale, lower scores, more impaired. We then statistically analyzed this data, and I'm going to share really one slide that I think, or two slides that actually are very, very illustrative when it comes to discussing these patients. So most patients with severe symptomatic peripheral arterial disease were male in our state. 61% of the patients with claudication were male. 56 of the patients with critical limb ischemia were male. Most of these patients are older. And these patients are among the sickest patients that I think we take care of. Their comorbidity list is quite extensive. They almost all have hypertension. Almost half of patients with claudication and almost 60% of patients with critical limb ischemia have diabetes. Almost a third have chronic lung disease. Look at this. Over 50% of patients with critical limb ischemia are anemic. A quarter have had a prior cerebral vascular event. Almost 10% patients with CLI are on dialysis and have renal failure. Almost all have hyperlipidemia. More than half have coronary artery disease. And then a quarter of patients with critical limb ischemia have a history of heart failure. Very, very sick population. These patients who need a multidisciplinary approach to their medical management. They need excellent primary care. They need tight control of their diabetes and hypertension, and then to be managed by vascular experts as well. So when we looked at the PAQs of these patients at baseline, here for critical limb ischemia patients, again, these are patients that are in the significantly impaired category before revascularization. Look at the change in function after revascularization percutaneously, significantly improved into the moderately impaired range 6 months after the revascularization procedure, so relatively sustained improvement. Claudicants, as you might expect, were somewhat less impaired and statistically significantly so, but still in the moderately impaired range. So these patients, as a group, had significant impact on their quality of life related to their lower extremity disease. And again, these patients demonstrated significant improvement across two PAQ summary scores to over to the mildly impaired range. Again, 6 months after revascularization, so relatively, in the short term at least, sustained improvement in quality of life. So this is a selected group of patients who have significant disease, who required revascularization, but across our state, these patients do benefit from revascularization when appropriately selected for these procedures. So symptomatic lower extremity peripheral arterial disease patients have, as mentioned, quite impaired quality of life. And percutaneous revascularization was associated in our state with dramatic improvement in health status 6 months after revascularization. As I mentioned, claudication patients have higher quality of life score than those with critical limb ischemia, as you might expect, and both improved after revascularization. Finally, I'll just mention that patients with symptomatic PAD have significant impairment in their quality of life. Revascularization in the short term works. Standardized validated quality of life measures may be useful in the clinical evaluation of these patients, and we've used them at Michigan Medicine in the past and continue to do so. And they may give us an objective measure of how the patients are doing in follow-up as well. And finally, patients, and probably most importantly, with symptomatic peripheral arterial disease have multiple comorbidities. They require guideline-directed medical therapy, exercise therapy, and in a select group of patients, appropriate revascularization. Thank you for your attention.
Thanks, Dr. Grossman. That was a great presentation to get us continuing on our PAD talk tonight. The next presenter we have is Dr. Kaja. Dr. Kaja is a clinical professor of radiology and cardiac surgery in the Division of Vascular and Interventional Radiology. His clinical interest is aortic disease and management of acute and chronic venous disease and peripheral arterial disease. His presentation today will be on the medical management of patients with peripheral arterial disease. So Dr. Kaja, I'm going to pass it over to you.
Thank you. Well, thank you all for joining us this evening, and thank you to my colleagues from the Cardiovascular Center for including me, as well as learning from all of them. So here are some disclosures that are not relevant to this presentation. As my colleagues Ann Luciano and Dr. Grossman have already sort of prefaced, there are very sick patients that we're dealing with, and they have a lot of comorbidities. And so as the interventional radiologist, I thought it would be great to talk a little bit about the medical management of these patients, because it's very, very important to their long-term outcomes. So a few things that we really like to focus on, as you've heard about, is the guideline-based treatment of these patients. And so number one, as we know, is the largest preventable risk factor in patients with cardiovascular disease is smoking. And so, as we know, smoking contributes to the progression of disease. It increases mortality. It increases the failure of revascularization, whether it's surgical or endovascular, and really should be discussed with every patient. And we are very proud of our smoking cessation team in that they're able to see every patient that we refer them to, which is all patients that we see with peripheral arterial disease. The question should be asked every time we see a patient, and we're very happy to do that. Just a little bit of data behind this. The reason that smoking cessation teams are so important is that counseling has been shown in randomized controlled trials to improve the rate of smoking cessation. So there was a study looking at this. It was an RCT of about 124 patients, so not a large number, but it looked at intensive counseling and pharmacotherapy compared to just advice or suggesting you should quit smoking. And the rate of cessation improved in these patients from 6.8% to 21.3% with a p-value of less than 0.05. So it's very important to have that conversation, but then to refer these patients to a team of counselors as psychologists, and those who are really able to tackle some of these problems. Another major factor, as Dr. Grossman just showed us, was hyperlipidemia. I think in his slide, nearly 89% of patients with critical limb ischemia have hyperlipidemia or dyslipidemia. And all patients with PAD really should be treated with a statin. And this is coming from the AHA guidelines and numerous other papers. Statin therapy, as we know, improves cardiovascular and limb outcomes pre and post intervention. So we all like our tasty treats here with donuts and burgers. But it's really important to note that studies have shown, and large studies, randomized studies of thousands and thousands of patients, nearly 10,000 in this study, in patients post myocardial infarction were shown those who were treated with either simvastatin or atorvastatin, so high dose potent a statin, really had improved rates of not only their coronary artery disease, but specifically also their peripheral arterial disease. And so it's really important for us to make sure that we are including these patients that we see and starting them on a statin. And again, that is a measure that we use in the state of Michigan to evaluate sort of how we are doing. And so there's a good reason for that. Another common risk factor, I think in about 50 to 60% of patients, is diabetes. And so diabetes, again, is a very important risk factor in the development of patients with all cardiovascular diseases, but peripheral arterial disease specifically. These patients have an increased risk of progression of their PAD, their claudication, to critical limb ischemia, which could result in amputation or death. They've got poor wound healing, as we know, and it's really important to sort of manage this. PAD patients with a higher hemoglobin A1C, as you all know, have lower rates of amputation compared to those with A1Cs greater than 9.5. So getting tight glycemic control is really essential in these patients. And so again, we work with those who refer our patients in order to really get their diabetes under control along with the other factors. When we look at the different types of medications, pharmacologic therapies, we really break it down into a couple groups of anticoagulation, antiplatelet agents, and a few others. So what has the data shown? Well, according to some randomized controlled trials looking at aspirin therapy versus clopidogrel or Plavix, they really found no significant difference in endpoint of stroke, MI, or vascular-related death. However, there was a significant decrease in the primary endpoint, which was all-cause mortality in patients with PAD on clopidogrel following interventions. So again, it's really important for us and is part of one of the measures looking at the PVI registry as to whether we have started a patient on an antiplatelet agent following intervention. When we talk about the age-old battle or discussion of whether dual antiplatelet therapy or aspirin alone, really there was no significant difference in patients, in most patients, except for those with prior MI, stroke, or those with symptomatic claudication. And when looking at different agents, there was really no significant difference as well with similar bleeding rates. So it's important, again, for us to put the patients that we see on the right medications and using the data to help support our decisions. The AHA guidelines, again, highlight that aspirin or clopidogrel should be used in patients with peripheral arterial disease interventions. Another category is cilostazol and pentoxifylline. A Cochrane review found improvement in symptoms with no significant change in cardiovascular-associated death when compared to a placebo. And we know that cilostazol is contraindicated with patients with CHF as it may cause additional edema. But again, it's something that we try many of our patients on as along with the supervised exercise, which I'll mention on the next slide. Pentoxifylline, however, was really found no difference in these patient population, is no longer recommended in the treatment of peripheral arterial disease. So two other trials I want to just briefly highlight are the COMPASS trial, which looked at coronary artery disease as well as peripheral arterial disease, and looked at patients receiving rivaroxaban or Xarelto 2.5 as well as aspirin, and then separately. And basically in these patients, what this study found was that there was an overall improvement. So this combined rivaroxaban and aspirin treatment is this lowest line here, but they had a reduction in cumulative incidence of cardiovascular death, stroke, and MI in patients who were treated with these with very minor complications associated. A COMPASS trial looked specifically looking at the PAD subgroup, also found the same findings. So in those patients who were treated with low-dose rivaroxaban and aspirin, had an improvement in death, MI, and stroke, as well as major adverse limb events. And so really the medication management is nearly just as important, if not more important in many of these patients as the intervention that we may be performing. There was a final trial looking at peripheral arterial disease specific patients. This was a double-blinded randomized controlled trial of over 6,000 patients and looking at efficacy outcome over acute limb ischemia, major amputation, MI, stroke, or death from cardiovascular events, and watching safety of these patients with major bleeding since we're putting them on medications. And this was the Voyager trial that was published in the New England Journal of Medicine some years ago. And this study again found that there was a benefit in patients receiving rivaroxaban over placebo in overall outcomes. Finally, supervised exercise therapy that Dr. Grossman mentioned, I believe Dr. Corrier will also discuss, has been very beneficial, found to be very beneficial to patients compared to optimal medical therapy alone, and really should be considered prior to and after revascularization. As Dr. Grossman alluded to, the CLEVER study looked at patients who received optimal medical therapy alone, as well as those who had medical therapy, supervised exercise therapy, and those who had endovascular revascularization. And it found that patients had improved treadmill walking time at 6 months compared to revascularization alone. And patients with endovascular treatments had more improvement of their symptoms and quality of life. So again, this gets back to what Dr. Grossman was discussing about the patients and their overall outcomes, and their quality of life is really important. So they're able to walk further, have less pain, and really get along with their day. And this has been found in numerous studies following, and findings have been carried out up to 18 months, and I believe even longer at this point. So just in conclusion, revascularization with endovascular surgical techniques may provide a significant benefit for patients with peripheral arterial disease. And many of us on this webinar are really focused on interventions that we can take to help patients with this, but it's really important to consider the lifestyle modifications, supervised exercise, and risk factor reduction in these patients. And we really focus on all of those along with our referring providers in order to get the best outcomes for our patients. And as finally, as Anne highlighted in the beginning, what's really important to us at the Franco Cardiovascular Center is really collaborative care of these patients. So if there's something that I don't know, I may get on the phone and call Dr. Grossman, I may call Dr. Corrier or any one of the other colleagues, say, you know, I think this patient really needs a combined effort here to figure out what's the right thing for this patient, sometimes even a hybrid sort of type of procedure. So thank you.
Thank you, Dr. Kaja. These first presentations have been great, tying in all of the care that our patients receive at the Frankel Cardiovascular Center. We're going to pause before we go over to Dr. Corrier just for a few questions, and then we'll get started with the final presentation. So the first comment is, a lot of our patients with diabetes, as we know, it's difficult to keep their A1Cs even below 9.5. Or even to keep them below 6.5 and 7. But is there any data that there's fewer amputations or fewer procedures for an A1C between 8 and 7, if that is a more likely target?
I personally don't know the specific data for reduction in procedures, if that was the question. But Dr. Grossman, I think, has a comment as well.
Yeah, so there's quite a bit of data that suggests that patients with higher hemoglobin A1Cs have worse outcome with revascularization than those with lower. And so certainly when we see patients, we do everything we can to work with primary care and endocrinology if necessary to try to get these A1Cs down as we're anticipating or thinking about revascularization, either percutaneous or surgical. And I'm sure Matt can comment on his approach in diabetic patients with poorly controlled diabetes in thinking about what procedures, what surgeries to offer and the timing of those as well.
Yeah, I agree. And, I think the critical contingency there is, what is the scenario? Because oftentimes we meet these patients and we're not really doing a focused talk on limb threatening ischemia tonight, but often we meet them when they're in a very active, infected and or non-healing wound situation where we may have to proceed with a revascularization so we don't lose further ground while we're simultaneously trying to fight the battle, getting their glucoses more tightly controlled. On the other side, we know our patients who don't have critical ischemia, some of the biggest drivers of them progressing to critical limb ischemia are smoking, poorly controlled diabetes, and renal failure. And so we definitely would want to do everything we can to get their A1C under control before an intervention in the absence of, rest pain or an ulcer on their foot. I also think, it can be a real challenge in how long do we pound the rock on their glucoses before we, declare victory or defeat. And that's often a very continuous process with a lot of different data points to check on. But I think, for our poorly controlled patients, we tend to get aggressive early if they have a wound on their foot or rest pain.
Perfect. Thank you, guys. And again, just to clarify, that question too, I don't think we have a lot of data for all the different hemoglobin A1C ranges. For example, 8 to 9.5 or 7 to 8 or 6.5 to 7 with the rates of procedures and amputations. I'm not as familiar with any of that broken down specifically by all those A1C values, unless anyone has any from our panelists, any final comments on the specific ranges.
Certainly uncontrolled patients have a worse outcome. So greater than 9, those patients just aren't going to do well, unfortunately. But as Matt said, that may be the situation in some of the patients when they come in with very active critical limb ischemia or limb-threatening ischemia, and we have to do something as soon as possible to prevent either prevent an amputation or to limit the extent of the amputation that may be required. There's another question: if you could talk,
Yep.
could only talk to a patient into one medication or risk factor intervention, what is the most powerful risk factor to treat? Obviously, it depends on the individual patient. If I have a patient who's actively smoking, that's where I spend my time talking to them about smoking, getting them into our smoking cessation program, educating them about the benefits, even short term in quitting smoking. The day a patient quits smoking, the risk for adverse events goes down and continues to go down. Their lung function begins to improve. And certainly from the standpoint of management of their PAD, we feel like it has a great impact, not only in improving symptoms, maybe avoiding a procedure, avoiding progression of disease, but in those patients who need revascularization, the outcomes are better. To take it a step further, I make sure all my patients are on a statin. I think it's a simple thing that we can do. Again, we have great data that these patients avoid many of the complications associated with PAD, myocardial infarction, and stroke. And we also have very good data, again, from our own state, that patients act on a statin at the time of their revascularization procedure have a better outcome.
I agree with
Matt
that.
or Minaj, do you have any other comments, or Ann?
I agree with you exactly. I think smoking is number one for us as interventionalists doing procedures as well as surgeons. But a statin, as Dr. Grothman mentioned, is very important because it reduces all their coronary as well as their stroke risk and their PAD and renovascular issues as well.
Perfect. And with anyone, if you are deciding to do a procedure on them, do you want them to be completely smoke-free before you operate on them? Or if they're a 2-pack, making any kind of reduction to 1-pack, where do you guys kind of stand on their smoking cessation journey and their interventions?
I think that's a tough question. I think what's really important is separating out claudicants from patients with critical limb ischemia. And those with critical limb threatening ischemia, we appreciate and recognize how hard it is to quit smoking, but any improvement in that can be beneficial to them in the long run. Whereas those with claudicants, we really want to focus on lifestyle modification in order to get better outcomes without potentially having to do an intervention. And if you have to do an intervention, trying to reduce smoking as much as possible, almost to the point of not smoking, is ideal. But I open it up to my colleagues also to comment.
Yeah, I think sometimes we artificially think about smoking as kind of an either or thing. And it's very common for patients to quit and have relapses after, quitting. I saw a patient in my clinic today who has been trying to quit for 10 years and finally quit. And I think that notion that Dr. Kaja mentioned of just persistence, we need to treat that interaction with the patient like we're partnering with them. We need to remember it's a really powerful addiction and be aggressive about pulling the trigger on pharmacotherapy to support smoking cessation. And we actually have, some remote coaching support available through our clinic. And we just need to kind of grind on that, always ask about it, always support it, and never let it go. And it's a really big victory when you do get one of these people that have been smoking for 20 years that finally quit. It kind of made my day when that patient told me that today.
Great. Yeah. Thanks for sharing that. And Dr. Kaj, I think you answered that question very well. And it's a tough situation for all of our patients. So we're going to get back into our presentations now with Dr. Corriere. He is an associate professor of surgery in the Department of Surgery at University of Michigan. His clinical interest is in peripheral arterial disease, renal and mesenteric vascular disease, aortic and carotid disease. He's going to be tying together our presentation with a structured team-based approach to the treatment of claudication. I'm going to pass it over to you, Dr. Corriere. Oh, Dr. Corriere, I'm going to.
Can you hear me now?
Yes.
Okay, thank you. As the final presenter, I promise we'll be done on time. I appreciate the opportunity to talk about claudication. I think it's unique and one of the more controversial areas of PAD care, and one that I think I find interesting primarily because the areas for improvement with claudication are the extremes of undertreatment and overtreatment, in my opinion. What is claudication? Well, it's fatigue, discomfort, cramping, or pain of vascular origin in the muscles of the lower extremities that's consistently induced by exercise and consistently relieved by rest within 10 minutes. So that definition is crucial to discerning if the patient's likely to benefit from treating their claudication. And it's also the most common form of symptomatic PAD. And that reference and that guideline comes from this 2016 AHA guideline, which I was lucky enough to be in the writing group for, and is another great example of kind of a multidisciplinary collaboration where everybody had the same interests and goals that we tried to bring that same kind of collaborative air to our program. How is claudication different from the more severe PAD we were just talking about? Well, one big difference is that with appropriate risk reduction pharmacotherapy, most of these patients are actually at quite low risk of amputation, and the symptoms are often stable. And as I mentioned, it's really smokers, diabetics, or particularly smoking diabetics that are likely to progress from claudication to chronic limb-threatening ischemia. Another big difference is we really base what treatment interventions we move forward with on their symptoms, and that can be their symptoms at baseline. And if we implement a quantum of treatment, we want to bring them back and assess how did their symptoms respond, and kind of make a graded judgment on how much treatment is enough without being too much. And because the symptoms are such an important driver of what we do, it really requires a partnership between the patient and the healthcare team. If we want to be successful, we need to listen to what the patient tells us, consider it carefully. We need to be sure we're on the same page in terms of our expectations and goals to have outcomes that we both view as successful. My distinguished colleagues have already covered kind of the top bullet points here. The components of claudication treatment include the risk reduction therapy measures that we've discussed. And with claudication, then we jump into symptomatic therapy. And symptomatic therapy kind of consists of three main components. There's pharmacotherapy with cilostazol, and I think pentoxifylline has kind of fallen by the wayside. Cilostazol is really the only widely, used FDA-approved medication for claudication. There's a couple forms of exercise therapy I'm going to get into a little more detail about, and then revascularization. So those are the big buckets of our treatment options for these patients. Cilostazol improves claudication symptoms versus placebo, and it increases walking distance. And that's based on randomized data. And I have some references at the end with a Cochrane review that comes from. Side effects aren't uncommon with cilostazol, though, and about 1 in 3 to 1 in 5 patients can complain of headache, GI symptoms, or heart palpitations. It's important to prep the patient to anticipate that and let you know if it's not working so we can kind of course correct. It's also contraindicated in patients with congestive heart failure. So that's a big part of our clinic intake when we're considering treatment options in a patient with claudication symptoms where pharmacotherapy hasn't been tried yet. In terms of exercise therapy, there's kind of two levels of it. The more common and widely utilized and best evidence based is what they call supervised exercise program. And that takes place either in a hospital or an outpatient facility. And it's usually with a treadmill. It can be standalone or part of a cardiac rehab program. Ours at Domino's Farms here is available within a cardiac rehab co-located with it. It's directly supervised. There's a healthcare provider, usually an exercise therapist, there observing and monitoring the patient and helping them develop a tailored, personalized approach to their program. It's a minimum of a half hour to 45 minutes per session, at least 3 times a week, for a minimum of 12 weeks. So this is a commitment for the patient, and we have to be sure that they're up for it and are willing to commit. They do basically intermittent bouts of walking, alternating with periods of rest and warm up and cool down. This is the website where we offer it internally. Although, if we have a patient that comes from a distance, we also have a way to collaborate and identify a supervised program within their community because it's impractical for someone from out of the county, out of town to show up that much, especially with gas prices as they are these days. More recently, we've had the availability emerge of these structured or community home-based exercise program. This takes place in the patient determines where the walking occurs. So it's not in a clinical situation with one of us directly monitoring them. We give guidance, but the patient kind of self-directs the prescribed exercise regimen. We have to be sure the patient understands how to start, how to maintain the program, and how to progress. And goal setting is very important for these home-based programs. And it may also incorporate behavioral change techniques like coaching or activity monitors with tailored messaging associated with the activity. This is a recent publication that's in press right now where we enrolled out of our multidisciplinary PAD clinic this app-based approach for home exercise. It allowed patients to self-administer a 6-minute walk test in the community. The majority of these patients were free from a procedural intervention at 12 months, suggesting that it helped them in terms of symptoms. And they also set these SMART goals defined, SMART goal is specific, measurable, achievable, relevant, and time bound. And 92% of the participants in this study actually achieved their SMART goal over the study period. So this is some evidence that these programs work. And I'll also say that in the era of the COVID pandemic, we really leaned a lot more heavily when a lot of the structured exercise shops were shut down on this because there wasn't another good option for our patients. In terms of revascularization for claudication, it really should be used selectively on appropriate patients who have persistent lifestyle limiting symptoms, and it's added to existing therapy rather than replacing it. So if we've got them on risk reduction therapy, we've added cilostazol, and they've done exercise. Adding revascularization doesn't eliminate any of those upstream steps, but we kind of want them to try these lower risk interventions before committing to revascularization. We have to know if the symptoms are negatively impacting activities of daily living. And this concept of starting with low risk interventions and knowing when to stop. I had a patient today who improved enough on cilostazol that she didn't want to be referred for exercise and didn't need a revascularization. If we had just pulled the trigger on a procedure on her, it might have made her better uh, as well. But it's an avoidable risk, and we can save that for later in that patient. So we need to give patients a chance to get better with these lower risk interventions. Good candidates for revascularization for claudication are those that have lifestyle limiting symptoms, didn't respond adequately, or couldn't tolerate cilostazol. They're on the appropriate risk reduction medications and they're tobacco free. And I'm a pretty hardline person with not intervening on a smoking claudicant. You should question doing a revasc on a claudicant if they're smoking, if they have other comorbid conditions that limit their walking more than their leg pain, if they have isolated tibial disease, they're younger than 40, or they have leg symptoms that aren't consistent with PAD. And here's a table of some of the other stuff and how it's different. I won't go into so we don't go over time, but there's a careful history we have to put together with the exam and the test results to assess potential benefit. I've got a couple case examples here I'm going to run through very quickly. The first is a patient who came to our clinic for a second opinion. She had abnormal ABIs and had 2 procedures on her left leg for PAD over a year and was now being recommended to have her other side treated. And in talking to her, she actually was asymptomatic and was asymptomatic before the first procedure. We had to tell her that there weren't any additional need for treatment of this. She didn't actually need to be referred for anything because she had asymptomatic PAD, and the implications of the stents were reviewed. So this is an example of over treatment that's avoidable, and why I think one of the values of our shop is that we don't put a procedure on everybody that comes in the door just because it's possible and technically, not that hard to do. Here's a second example of kind of the other extreme of undertreatment of PAD, a 60-year-old woman who has some pretty severe comorbidities. She's got an AICD, has cardiomyopathy with mitral regurg, has diabetes, a former breast cancer survivor. She's used to be a smoker, but was tobacco abstinent for 10 years. And she had been previously followed by a vascular specialist who kind of said, "You're too high risk. There's no options for you." And she was referred to us after she self referred to a neurologist because she was out of options and was kind of scrounging for what else can be done for my leg pain. We did a CTA on her that showed iliac occlusive disease and kind of revisited and reset how bad was her CHF, how high was her risk. We could safely observe her without intervention, but she felt very strongly that she wanted a procedure and couldn't go on like this. We ended up taking her for an arteriogram after getting our cardiology colleagues to confirm that she was acceptable risk. This is a very simple, mild iliac lesion here. This procedure took, all of about 35 minutes to do. And she came back to clinic saying she got her life back. Her goals were met. She's dancing, able to go on vacations with her family, and is now asymptomatic. This is a great example of needing to listen to the patient and revisit what our goals are and what our risk tolerance is if they're off tobacco and don't have a lot of other good options. So these are the key takeaways: avoid overtreatment, avoid undertreatment, and tailor your approach based on the patient's goals. And I'll skip through the rest of this, but I would say we've got some innovative stuff coming out of our PAD clinic with how we do listen to patients and include patient reported outcomes and how we choose treatments. This summarizes our team. Those of us in the box and the vascular specialists there are really part of the formal program, but we interface with the patient. The patient's a very important part of our team, as well as the referring primary care physicians and all these other individuals that we selectively involve as needed with these patients' care. It really is a team-based approach, which is a big thing here at U of M. And these are the references in case anybody wants them later. And I really appreciate everybody's time and listening to my presentation. Thank you.
Thank you, Dr. Corrier. That was a wonderful end to our presentation tonight. I just want to thank all of our presenters and Dr. Kaja, Dr. Grossman, Dr. Corrier. We're going to get into a few questions before we wrap things up tonight. So our next question is when to use phylastazole versus aspirin and or Plavix?
I think if they're symptomatic and you want to start and they have claudication symptoms, that's when I invoke cilostazol unless they have a contraindication. I think if you have a patient with asymptomatic PAD or limb-threatening ischemia, there's probably not much of a role for it. If the patient's tolerating it and has a partial response, I tend to continue it because just like I think Dr. Kaja touched on, it's got some pleiotropic beneficial effects on patency that I like. And I really don't worry about the bleeding risk that you add by combining cilostazol and aspirin. It's really minimal.
I agree with that completely. I think adding an aspirin and Plavix or even rivaroxaban, which is really important, is for patients following revascularization. So those medications are beneficial in patients who have any sort of endovascular or surgical procedure. The data supports that. So even if they've had just an angioplasty, they benefit from aspirin and rivaroxaban. And when a patient has a stent placed, frequently there's a benefit with Plavix, at least in short-term patency. So I agree with Dr. Corrier regarding the cilostazol as a first-line treatment as well.
What about with patients who take cilostazol and don't have any improvement with their distance walking? Would you leave someone on that if they reporting no improvement?
I usually don't.
Okay. And then with the patients who have post revasc, do you leave people on the rivaroxaban indefinitely?
So,
That could be
I start patients on the aspirin and rivaroxaban combination because the data supports it, and usually keep them on for about 6 months. But I don't have the specific data as to the long-term use of that, and I don't know if Mike or Matt have some additional information.
Yeah, I agree with that. I think it's particularly important in a young patient who has a long lifetime where that patency has to be maintained for a decade or more. I'm a little more selective with it if I have an older patient who's got a gait or balance issue or there's something else going on. And I usually start it at the follow-up visit when they're kind of out of the window if they've had a procedure for bleeding stuff. Mike, do you do
Yeah,
similar?
I agree. If we're going to use, you know, a DOAC long term, got to be very aware of bleeding risks in those patients. But I think, as was already mentioned, long term patency of a bypass graft or even a percutaneous procedure is even more relevant in a young person. So anything we can do to keep that vessel open. And the other thing to mention in patients after a procedure is we follow them closely. We not only follow them for symptoms and you know um, uh, compliance with good medical therapy and not smoking, but follow their bypass graft or follow the intervened upon limb, whether it's with a stent or just a balloon procedure, in our vascular lab. And it's much better to catch these patients when they're starting to develop recurrent symptoms. Peripheral arterial disease is most of the time is not a one-time fix and then the patient's done. It's a chronic disease and needs to be treated as such and followed very closely, not only by primary care physicians but by a vascular specialist for those particularly who have more advanced disease and have already had a revascularization procedure.
wonderful. Thank you guys. Um, We just want to say thank you for everyone who came to our presentation today. I want to thank again the presenters and Dr. Grossman, Dr. Kaja, and Dr. Corrier for a wonderful night of discussion for patients with peripheral arterial disease. I hope everyone has a greater understanding of what we can do prior and post procedure, and how to prevent, maybe some revascularization procedures as well. Again, at the Frankel Cardiovascular Center, we have a multidisciplinary program to treat peripheral arterial disease. We're always here to answer any questions, and we'll stay on for any final questions. But if not, we appreciate everyone's participation. And
I
um,
wanna, if it's okay, I wanna acknowledge Ann Luciano too, even though she's not screen sharing. I don't know if she's being bashful, but she's the real backbone of our program. And she is the face that most of our patients see every single time they come in. And she's really the linchpin of this enterprise, and we couldn't do it without her. Thanks, Ann.
Thank you, Anne.
Absolutely. Thanks very much, Ann.
yeah, thanks, Anne. I mean, you've said it. You've been here for a very long time, and you've done great for our patients. And they see you in the office, and you're probably the reason why those scores are so high. It's all the great care everyone gives. So again, thank you guys.
Good night, everyone.